So it's Renin, Angiotensin, Aldosterone system. Whenever BP is decreased or there's less sodium delivery in the distal convoluted tubule or more sympathetic tone because of beta receptors, we sense there's decreased BP. In distal convoluted tubule, there are special cells called maculodensa cells for sensing sodium, and there's a JG apparatus beside distal convoluted and afferent tubule, which sense everything and is responsible for secretion of renin. In afferent arterial, blood comes in glomeruli and goes to efferent arteriole. So BP is coming less, and these cells secrete renin. Renin goes in the blood and goes in the liver where there's angiotensinogen and it converts angiotensinogen to angiotensin 1. Now renin has done its job in making angiotensin 1. We are sending angiotensin 1 in the blood which goes in the liver and lungs and entire body, especially in the lungs. There's an enzyme ACE, angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. Angiotensin 2 is made, which is of importance in the system. Now, because of low BP, we made renin. Renin made angiotensin 2. Angiotensin 2 is gonna act on different vessels and vasoconstriction and increase BP. So, the angiotensin 2 increases BP by vasoconstriction. Then it's acting on efferent arteriole by constricting this vessel, and it's gonna constrict and increase GFR and increase filtration fraction. Efferent is constricted, okay? In the kidney, angiotensin 2 is going in proximal convoluted tubule and increasing activity of sodium proton exchanger. So we are having more sodium inside. In proximal convoluted tubule, angiotensin is increasing activity of sodium proton exchanger. Sodium is coming inside and proton is going in the urine. So angiotensin 2 is increasing activity of this antipode, sodium proton antipode in proximal convoluted tubule, increasing sodium reabsorption and increasing proton excretion. So increasing sodium proton exchange in PCT, which increases sodium and water reabsorption, but obviously we are losing more proton, and because of that we are having contraction alkalosis because we are losing more proton. In exchange of sodium, we're losing proton, and we are making alkalosis. This is called contraction alkalosis. And then in kidney, angiotensin 2 also increases aldosterone productions. That is the reason it's called renin angiotensin aldosterone system. Aldosterone increases, aldosterone acts on the collecting tubule, and in collecting tubule, it acts on two cells, alpha intercalated cells and principal cells. In alpha intercalated cell, we lose proton. Proton is excreted in principal cells, we lose potassium. Alpha is for proton, principal is for potassium, P for potassium, P for principal. Alpha is for proton secretion. Both are being secreted out. In alpha intercalated cells, we have more ATPase activity of proton pump. That is secreting proton ATPase activity. In principal cells, we are having more potassium conductance, more e-neg activity, and more sodium potassium ATPase activity. More conductance of potassium, more e-neg activity, and more ATPase. A lot of mechanisms. I can't remember that. Now, angiotensin 2 is also going to hypothalamus, increasing thirst, which is something we always forget, and it's acting on the pituitary and increasing ADH. Angiotensin increases ADH and which increases aquaporin. So angiotensin also increases ADH production from pituitary and increases thirst and water reabsorption. something to note, okay?